Dear future doctors, today, we are going to discuss one of the most encountered chest diseases nowadays, and that is obstructive lung diseases. Second entity we will be discussing is the chronic obstructive pulmonary disease, also known as COPD. COPD is a preventable and treatable disease characterized by persistent airflow limitation that is usually progressive, and associated with an enhanced chronic inflammatory response in the airways and the lung to noxious particles or gases. Exacerbations and comorbidities contribute to the overall severity in individual patients. COPD patients also suffer from extrapulmonary effects including weight loss and skeletal muscle dysfunction. On the other hand, commonly associated comorbid conditions include cardiovascular disease, cerebrovascular disease, the metabolic syndrome, osteoporosis, depression and lung cancer. There are two main subdivisions of COPD, namely chronic bronchitis defined as cough and sputum on most days for at least 3 months, in each of 2 consecutive years, and emphysema, which is characterized by abnormal permanent enlargement of the air spaces distal to the terminal bronchioles, accompanied by destruction of their walls and without obvious fibrosis. Emphysema may be classified by the pattern of the enlarged air spaces as centriociner, paniciner or paraseptal. Ballaiform in some individuals, resulting in impaired gas exchange. This diagram illustrates the difference between normal alveoli and alveoli affected by emphysema. Epidemiology and etiology. The prevalence of COPD is directly related to the prevalence of tobacco smoking, and the risk of developing COPD relates to both the amount and the duration of smoking defined in pack year. Not all smokers develop the condition, suggesting that individual susceptibility factors are important. Current estimates suggest that 80 million people worldwide suffer from moderate to severe disease. By 2020, COPD is forecast to represent the third most important cause of death worldwide, and the anticipated rise in morbidity and mortality will be greatest in Asian and African countries, as a result of their increasing tobacco consumption. There are a group of risk factors for development of COPD. Some are environmental and some are host factors, the most important of which are tobacco smoking, indoor air pollution as cooking with biomass fuels in confined areas, which is widely practiced in developing countries, and occupational exposures, such as coal dust, silica and cadmium. This figure summarizes the main pathophysiological features in COPD, both pulmonary and systemic. Pulmonary pathological changes results in pulmonary hyperinflation with the following physiological changes: flattening of the diaphragm, an increasingly horizontal alignment of the intercostal muscles, placing the respiratory muscles at a mechanical disadvantage. Also, the work of breathing is markedly increased, first on exercise, but then, as the disease advances, it occurs at rest as well. Clinical features in COPD patients are as follows: ages 40 years or more, cough and associated sputum production are usually the first symptoms, often referred to as a smoker's cough. Hemoptysis may complicate exacerbations but should not be attributed to COPD without thorough investigation. Breathlessness, the severity of which should be quantified by documenting what level of exertion the patient can manage before stopping according to Modified Medical Research Council dyspnea scale or the Modified MRC dyspnea scale. This dyspnea scale defines the degree of dyspnea into 5 grades. Grade 0 where there is no breathlessness, except with strenuous exercise. Grade 1 where there is breathlessness when hurrying on the level or walking up a slight hill. Grade 2 where patient walks slower than contemporaries on level ground because of breathlessness or has to stop for breath when walking at own pace. Grade 3 where the patient stops for breath after walking about 100 meters or after a few minutes on level ground. Grade 4 where the patient is too breathless to leave the house, or breathless when dressing or undressing. Local chest examination reveals signs of hyperinflation demonstrated during inspection, percussion and auscultation. All these physical signs will be shown clinically during the demo session. It is worth mentioning that 2 classical clinical phenotypes have been described. The first is pink puffers, in which the patient is typically thin and breathless. and maintain a normal partial pressure of carbon dioxide until the late stage of disease. The second is blue bloaters, in which hypercapnia develops earlier and may develop edema and secondary polycythemia. In practice, these phenotypes often overlap. Diagnosis requires objective demonstration of airflow obstruction by spirometry. This will be detailed in our mini-lecture. The Global Initiative for Chronic Obstructive Lung Disease Stages of COPD Patients according to FEV1 will also be discussed in our mini-lecture. Other important tools include arterial blood gases to demonstrate hypoxia and/or hypercapnia. Please refer to arterial blood gases lecture studied during second year. Measurement of lung volumes provides an assessment of hyperinflation. Exercise tests provide an objective assessment of exercise tolerance and a baseline for judging response to bronchodilator therapy or rehabilitation programs. They may also be valuable when assessing prognosis. Imaging such as chest X-ray is essential to identify alternative diagnoses, such as cardiac failure, other complications of smoking such as lung cancer, and the presence of bullae. Also, high-resolution CT is likely to play an increasing role in the assessment of COPD, as it allows the detection, characterization and quantification of emphysema. Finally, the assessment of health status provides valuable clinical information. The St. George's Respiratory Questionnaire is a commonly used research as well as the COPD assessment test, which employs only 8 questions, and the scores correlate closely with the St. George's Respiratory Questionnaire. Management. The main goals include help breathlessness, reduce the frequency and severity of exacerbations, enhance the health status, improve the prognosis. This slide shows the Global Initiative for Chronic Obstructive Lung Disease Guidelines for treatment of COPD, and it will be included in our mini-lecture along with the next 2 slides showing combined assessment of COPD and treatment by category. One of the important non-pharmacological lines in management of COPD is reducing exposure to noxious particles and gases. Smoking cessation. Reducing the number of cigarettes smoked each day has little impact on the course and prognosis of COPD, whereas complete cessation is accompanied by an improvement in lung function and deceleration in the rate of FEV1 decline. Indoor burning of biomass fuels. The introduction of non-smoking cooking devices or use of alternative fuels should be encouraged. Pulmonary rehabilitation is another important non-pharmacological line in managing COPD patients. Exercise should be encouraged at all stages, and patients reassured that breathlessness, whilst distressing, is not dangerous. Programs that incorporate physical training, disease education and nutritional counseling reduce symptoms, improve health status, enhance confidence and are accompanied by sustained improvements. Most programs include 2 to 3 sessions per week for 6 and 12 weeks. Long-term domiciliary oxygen therapy is indicated when partial pressure of oxygen is less than 7.3 kPa irrespective of partial pressure of carbon dioxide and FEV1 less than 1.5 liters. Partial pressure of oxygen is 7.3 to 8 kPa plus pulmonary hypertension, peripheral edema or nocturnal hypoxemia. Use at least 15 hours daily of it 2 to 4 liters per minute to achieve a partial pressure of oxygen more than 8 kPa or saturation of oxygen to at least 90% without unacceptable rise in partial pressure of carbon dioxide. Also note that arterial blood gases should be measured in clinically stable patients on optimal medical therapy on at least 2 occasions 3 weeks apart. Surgical intervention is indicated in COPD patients in the following conditions: patients in whom large bullae compress surrounding normal lung tissue, who otherwise have minimal airflow limitation and a lack of generalized emphysema, and the surgery of choice is brolectomy. Patients with predominantly upper lobe emphysema, with preserved gas transfer and no evidence of pulmonary hypertension, and these patients usually undergo lung volume reduction surgery. Selected patients with advanced disease may benefit from lung transplantation. Prognosis. COPD is usually progressive. The prognosis is inversely related to age and directly related to the post-bronchodilator FEV1. Respiratory failure, cardiac disease, pulmonary embolism and lung cancer represent common causes of death. A composite score comprising the body mass index, the degree of airflow obstruction, a measurement of dyspnea and exercise capacity may assist in predicting death. In the score, the four variables are given points from 0 to 3 and according to the total score of points, the approximate 4-year survival rates can be estimated. Acute exacerbations of COPD are characterized by an increase in symptoms and deterioration in lung function and health status. They become more frequent as the disease progresses, are usually triggered by bacteria, viruses or a change in air quality. They may be accompanied by respiratory failure. Many patients can be managed at home with the use of increased bronchodilator therapy, a short course of oral corticosteroids and, if appropriate, antibiotics. Presence of cyanosis, peripheral edema or an alteration in consciousness indicates the need for referral to hospital. In other patients, consideration of comorbidity and social circumstances may influence decisions regarding hospital admission. Management. Antibiotics are reserved for patients reporting an increase in sputum purulence, sputum volume or breathlessness. Simple regimens are advised, such as iminopenicillin or macrolide. Coamoxiclav is only required in regions where acetylactamase-producing organisms are known to be common. Oral prednisolone reduces symptoms and improves lung function. 30 mg for 10 days are recommended, but shorter course. Nebulized short-acting CETA2 agonists, combined with an anticholinergic agent as salbutamol and ipratropium, should be administered. Controlled oxygen should be used with the aim of maintaining a partial pressure of oxygen above 8 kPa or saturation of oxygen between 88 and 92% without worsening acidosis. Intravenous infusions of aminophylline may be given, but evidence for benefit is limited and there is an associated risk of inducing arrhythmias and drug interactions. Non-invasive mechanical ventilation is used in persistent tachypneic, hypercapnic and acidotic patients and if failed, shift to invasive mechanical ventilation. As for the old age group, the following points are noted. Asthma may appear de novo and old age, so airflow obstruction should not always be assumed to be due to COPD. Older people with poor vision have difficulty reading peak expiratory flow meters. Perception of bronchoconstriction is impaired by age, so an older patient's description of symptoms may not be a reliable indicator of severity. Many older people cannot use metered dose inhalers because of difficulty coordinating and triggering the device. Even mild cognitive impairment virtually precludes their use. Frequent demonstration and reinstruction in the use of all devices are required. Mortality rates for acute asthma is higher in old age, partly because patients underestimate the severity of bronchoconstriction and also develop tachycardia and pulsus paradoxus for the same degree of bronchoconstriction. The benefits of cessation of smoking on the rate of loss of lung function decline with age but remain valuable up to the age of 80. Finally, for treatment decisions, it should be noted that advanced age in itself is not a barrier to intensive care or mechanical ventilation in an acute episode of asthma or COPD, but this decision may be difficult and should be shared with the patient if possible, and with the relatives and the physician. Asthma-COPD overlap syndrome includes a group of patients with an overlap between clinical, functional and features of both airway inflammation patterns of both asthma and COPD. Prevalence of this group is between 15 to 55% and increases with age and is more among females. Asthma-COPD overlap syndrome should be suspected in a patient more than 40 years of age, with smoking history, previous asthma diagnosis or history of childhood asthma who has persistent airflow limitation and reversible airway obstruction defined by an increase of more than 12% of FEV1 predicted or increase of FEV1 more than 200 ml after inhalation of 400 micrograms salbutamol or 1000 micrograms terbutaline. Treatment will include inhaled corticosteroids in low or moderate doses. Long-acting beta agonists should also be continued. Main diseases in differential diagnosis of wheezy chest include bronchial asthma, COPD, asthma-COPD overlap syndrome, bronchitis, cystic fibrosis, and finally thank you for your kind attention.